But it's a pleasure to be able to speak to you today about the new guidelines that have been developed across Humber and North Yorkshire. And I think these guidelines represent quite a significant opportunity to drive improvement in the care for our asthma patients. And they're also a really nice example of how, at a geography as large as Humber, North Yorkshire, we've been able to work collaboratively across disciplines, across healthcare sectors, to come together with a unified guideline and formulary, which will I think help our patients and help us achieve what we set out to across our region. So I'm Michael Crooks. I'm a chest consultant and academic based down in Hull, and I work within our asthma service as well as within COPD. And these are my disclosures, and I think it's very important that these are displayed when we're talking about guidelines. So I do work with different drug companies on a range of different things, including research, and hopefully, and I think in fact, I have done one thing or another with nearly everybody who is reflected across the sphere of asthma and COPD treatments. So hopefully equally conflicted across the board. So I wanted to start off with a sneak peek at what the front page, or at least the front treatment page of our adult asthma guideline looks like. And I will take a fair bit more time running through this. But the reason I wanted to show you up front is that it takes a different approach than you will be used to if we have been working on local guidelines from across the region over time, and based on the kind of past NICE or BTS guidelines, which are due to be updated next year or so. The date keeps getting pushed back. And what you will see immediately jumps out at you as different compared to previous guidelines is that we now have two tracks. We have a preferred option for treating adult asthma patients, and we have an alternative option. And the alternative option really is for those that are not suited, in your opinion, to the preferred options. The preferred option should always be your go-to, and if there's a good reason not to, that's where you have the alternative. And the preferred option follows an anti-inflammatory reliever algorithm, essentially. And when I talk about anti-inflammatory reliever, and I'll talk about this in a lot more detail, we're talking about the use of an ICS, so an inhaled steroid, and formoterol as the reliever therapy in asthma, with or without that same combination inhaler as a regular maintenance dose. And that follows that all the way up until we get to the severe asthma cohort, which is really when you're thinking about secondary care referral. So why are we doing that? Well, we're certainly not alone. So these are the GINA guidelines. This is a global asthma report, which looks at the evidence across asthma treatment and makes recommendations which are relevant to a global audience. And you can see that actually GINA is structured in a very similar way to we have structured our guidelines. So they have a preferred route, which is based on ICS formoterol as the reliever, just like our new guidelines are. And then there's an alternative route, which is for those that are unable to use the preferred route and who you are confident will be adherent with their controller preventer therapy. And as Artie's already alluded to, the proportion of asthma patients that actually are adherent to the preventer therapy is very small, and that's where the preferred approach has many advantages. And within the UK, we're also not the first to come up with this approach. So as much as I would love to say we were absolute trailblazers, we're not quite. So the PCRS came out with a pragmatic approach to managing asthma. And on the second page of theirs, where they have their treatment pathways, we can see that pathway 1, which is their preferred pathway, is again based on ICS formoterol as a reliever rather than a SABA, and then with the addition of maintenance doses for all but mild asthma. So it's a massive step forward, I think, in terms of this within our region, but the precedent has been set both globally and within the UK already. So why have we taken this approach? So Artie has already talked you through asthma, and I think the key thing to emphasize is that asthma is an inflammatory condition. So it is a condition that is characterized by airway inflammation, and it's that airway inflammation that drives the variable airflow limitation that we see in asthma and the variable symptoms which we see in asthma of wheeze, breathlessness, chest tightness, and cough. And we know that at the time of asthma exacerbation, that markers of airway inflammation increase, and that then drives increase in symptoms, and that then drives increased reliever medication use. So here are two different illustrations of the time of an asthma exacerbation, both based on different studies from a number of years ago. But we can see the daily symptom score on the blue bars here, 0 being that date of exacerbation treatment, and this red line being the exhaled breath nitric oxide, which is a marker that is associated with airway inflammation. And we can see that airway inflammation rises within a couple of weeks before that exacerbation onset. That's then followed by that increase in symptom score, and that peaks at the onset of exacerbation, and with treatment, then that resolves. And in terms of treatment, we know that from this study from Tetrisfield, we know that people use the reliever inhalers more frequently in the run-up to an exacerbation, and then it's the commencement of oral corticosteroids that treats the airway inflammation and restores things to normal. So when we think about how people use the reliever inhaler in asthma, they use it to relieve symptoms. So the more often your patient is experiencing symptoms, the more sustained those symptoms are, or the more severe those symptoms are, then the more that person will use the reliever inhaler. And if that's a short-acting beta agonist, or SABA, these blue reliever inhalers, which is what the previous and traditional approach, I suppose, to asthma management was, it takes this angry, inflamed, and constricted airway, and through a series of downstream effects after binding to this beta-2 receptor in the airway, it relaxes the muscle and it restores the airway to a still inflamed but slightly less narrowed airway. Because we know that SABA does not treat airway inflammation. So this is a series of asthma patients not on inhaled steroids, exhaled breath nitric oxide before they had their SABA, and exhaled breath nitric oxide after having a SABA. And if anything, there's a slight trend to markers of airway inflammation having gone up, certainly, rather than coming down. So SABA does nothing to treat airway inflammation. And it's for that reason that while patients, when exposed to a trigger with their asthma, on a SABA-containing regime, they get that increased inflammation, they get the increasing symptoms, they're using their SABA reliever inhaler, it makes them feel better transiently, but ultimately they reach this crisis point where they end up presenting to primary care or ending up in the emergency department and requiring treatment with oral corticosteroids. And it's the steroids that then treat the inflammation and restore the airway to normal. Of course, I don't need to tell anyone that these oral corticosteroids, while important and life-saving treatments in this context, they have a broad range of long-term adverse effects, which cause a lot of morbidity for our patients in the longer term. So osteoporosis, cataracts, diabetes, all of the above. And because asthma is an inflammatory condition, and because of the importance of anti-inflammatory therapies, it's no surprise that as long ago as 2014, we recognized that excessive reliever use, and that's SABA reliever inhaler, and underprescribing of anti-inflammatory therapies, those preventer medications, was what was associated with asthma deaths. And this has been shown time and time again in repeated clinical studies that SABA overuse is associated with increased risk of exacerbations and increased risk of asthma deaths. So it's about time that we actually acted on that, and that's what these guidelines go away to doing. So what is anti-inflammatory reliever? So anti-inflammatory reliever refers to the use of an inhaler, a combination inhaler that has both an anti-inflammatory medicine, so an inhaled corticosteroid, as well as a reliever. And the reliever in the anti-inflammatory reliever inhalers is formoterol. And formoterol is a long-acting beta agonist, but it is also a fast-acting beta agonist. So I'll show you some data shortly, which shows that the onset of bronchodilation with formoterol is equivalent to that of a SABA. And as a result, you do not need the SABA inhaler as part of this regime. And when we talk about anti-inflammatory reliever, there's now two ways that we can use that. We can either use it just as needed with no regular preventer therapy in mild asthma, and we refer to that as anti-inflammatory reliever therapy or air therapy, or sometimes people might just call it as needed air. Or we use it alongside regular maintenance doses. And I'm sure you'll be much more familiar with this approach to using it as maintenance and reliever therapy. So where you use that same combination inhaler regularly, typically once or twice a day, and with additional inhalations for relief. So that's MART and is suitable for moderate up to severe asthma. And the theory behind that is when you get this exacerbation, when you're exposed to those triggers and you get increasing airway inflammation and the airway's angry and narrowed, that patient reaches for the reliever inhaler, but at that time they're getting the combination of both the steroid and the relief from the formoterol, which provides the symptom relief, but also tackles that inflammation early, and therefore prevents that patient from reaching this crisis point, preventing that exacerbation and preventing the need for corticosteroids. So that's the theory behind anti-inflammatory reliever, and it works in the same way when it's being used in mild asthma, just as required, as well as when it's being used alongside regular prevented doses with MART. So what is the evidence for this? It's all good and well me telling you it, but I'm sure you want to actually see that this is true. So this is some data from the early MART trials, and Symbicort's a combination of budesonide and formoterol, and then Foster is a combination of beclomethasone and formoterol. And I'm just showing these two examples because these were the molecules where the data's derived from. And these are both examples of methacholine challenges. So that's where you give somebody increasing concentrations of methacholine to inhale, and that causes the muscle around the airway to go into spasm and tighten, causing a drop in the FEV1, that measure which we use to quantify airflow limitation. And we can see the same on both sides. You give them methacholine, you get a drop in FEV1. And then these individuals were either given placebo, which just over time, the airway smooth muscle relaxed gradually, but it took some time. Or they were given salbutamol or the combination of budesonide formoterol on the left-hand side or beclomethasone formoterol on the Foster on the right-hand side. And we can see that the salbutamol and the combinations with formoterol follow an almost identical trajectory. On the right, it says Foster. That's just because that's the international name for Foster. That's what they call it in other countries. So anti-inflammatory relievers do work to provide relief. The formoterol is a very effective, fast-acting bronchodilator as well as long-acting. So where does the evidence come from? So in terms of anti-inflammatory reliever therapy, so where we're using these combinations in mild asthma, the evidence comes from trials of budesonide formoterol. We haven't had any trials yet in this mild population of beclomethasone formoterol. But for MART, we have evidence for both. So when I go through the subsequent studies with you, for just as needed in mild asthma, it's all based on budesonide formoterol. In the case of the trials, they were done with Symbicort. And for the MART trials, where we're using, we have data for both budesonide formoterol and beclomethasone formoterol. So here's the mild asthma, so just as needed. And I appreciate that this is a very busy slide, so I'm going to just highlight the key points on it. These are the data points from two different large randomized controlled trials looking at as needed ICS formoterol, so this was budesonide formoterol, versus SABA-only therapy. Now, we don't use much SABA-only therapy in asthma, or at least we shouldn't be using any SABA-only therapy in asthma because it is an inflammatory condition, but unfortunately, a lot of people still do. So this is the trial showing that as needed, ICS formoterol with no regular maintenance doses versus SABA-only therapy is associated with reduced frequency of exacerbations. So if you're on the left-hand side of this main line, we can see that this was in favor of ICS formoterol, and improved asthma control on the basis of symptoms. So again, on the left-hand side, favoring it. So ICS formoterol, budesonide formoterol, just as needed in mild asthma, is superior to SABA-only regimes in reducing exacerbations and in achieving asthma control. And that's probably no surprise because SABA doesn't treat inflammation, it doesn't treat asthma, just temporarily makes you feel better, whereas the ICS in ICS formoterol does. When we compare it in a clinical trial setting to regular low-dose ICS, so the typical kind of preventer plus SABA reliever, compared with as required ICS formoterol, so just as needed with no maintenance doses, we can see a trend overall to favoring just as required ICS formoterol, compared to regular ICS with SABA reliever. And in fact, in some of the studies, we could see that it was superior in terms of reducing exacerbations. And the difference between these studies was that the Sigma trials, where it just shows equivalence to regular ICS, were very well controlled randomized trials where patients were very adherent to their ICS monotherapy. So these patients had smart inhaler monitoring. They were using their inhaled steroids regularly as was prescribed, which is of course not what we see in the general population, whereas in novel start and practical, They were slightly more real world in the design of those studies, and adherence levels were lower, which is probably more akin to real world, which to me suggests that ICS formoterol, as required in terms of reducing exacerbations, is superior because it overcomes some of those challenges in terms of adherence. When we then just think about the evidence for MART, I'm not going to spend as long on that because we know that MART works. We've known it works for a very long time. There are multiple clinical trials showing that it works. And so maintenance reliever therapy, so combination ICS formoterol, both as regularly with additional doses as required, compared to fixed dose ICS lab regimes with a SABA reliever, are associated with significant risk or significant reduction in risk of exacerbation. So compared to an equivalent steroid dose, they reduce your exacerbation risk by 32%. And even associated with higher dose inhaled steroid containing fixed regimes, MART is associated with a reduced risk of exacerbation. So MART works. Here's just some real world data. So this is from Hull, in fact, and from a program called Sentinel, where we did a program to support implementation of a MART-based treatment guideline in order to address SABA overuse and improve outcomes. And on the left-hand side, we can see the proportion of patients before and after implementation of MART-based treatment algorithm, showing a reduction in the proportion of patients overusing SABA. So we had about a 50% reduction in that proportion of patients. And in terms of exacerbations, we saw a 30% reduction in the proportion of patients who were exacerbating in those that had a review as part of the program. So I think this shows that when deployed in a real world setting with patients that are using their treatments as they do out with a clinical trial, this approach to managing asthma is associated with positive outcomes. So just in the next kind of 5 minutes maximum, I promise, Jen, that I'll talk you through the guideline in a bit more detail. So the first thing that we have on the front of all our guidelines that we're issuing is a bit of a statement to say what these guidelines are intended for, who they're intended for in terms of the patients, but also to say that they are not designed to promote a kind of mass switch of inhaled therapies. We do not support switch programs which do not involve a review of the patient or discussion of the patient, because the challenge then is patients don't trust us, and they think that we're doing it for cost saving generally, and they like to know that we've made a change because there's a need. So that's what the guidelines are designed to support. So here's our blank template. So we have this little green symbol to show that it's the environmentally friendly option. So you'll see that alongside the inhalers, as well as alongside the preferred regime, because a MART-based and air-based treatment algorithm has a lower carbon footprint than the alternative, because SABAs have a high carbon impact. In those that are being considered for a suspected asthma diagnosis, and we can't immediately do objective testing, the preferred pathway recommends a combination of ICS formoterol for relief of symptoms. And I show you Symbicort first. We do have alternative options, but the reason I show Symbicort first is because it's the only licensed inhaler currently for use as required use only. And that's based on, as I said, that evidence being for the budesonide formoterol. Of course, we recognize that not everybody can use that, and it may not be appropriate for everybody, so you have alternative options where the licensed medication is not an option. Once you've confirmed asthma, it's the same regime. So for mild asthma, we have the option of budesonide formoterol as being the licensed preparation. And again, if that's not considered suitable for your patient, you have some unlicensed alternatives, which are mentioned, which have the same principle of the ICS with formoterol for relief of symptoms, but also treating that inflammation. For those that require additional treatment, you could add in an LTRA at this stage, so montelukast, but you may want to consider stepping up to maintenance reliever therapy. And the way that you do that is just by adding in regular doses of that same inhaler that they've been using for the anti-inflammatory reliever at that earlier step. So you start some regular preventer doses in addition to continuing to use that same device for relief. If needing additional therapy, again, you've got that option of adding montelukast. Where you need to step up further You can use maintenance reliever therapy with the addition of a long-acting antimuscarinic medication, such as tiotropium. We know that long-acting antimuscarinics, particularly for those that still have some persistent airflow limitation on therapy, can be very beneficial in terms of improving symptoms and reducing exacerbations. But you continue to use maintenance reliever therapy, so those regular inhalations of your ICS formoterol combination with that same inhaler, ICS formoterol inhaler, as the reliever, as MART. And if still uncontrolled on this step and maybe continuing to exacerbate, then you have some options of adding in additional therapies. So we have montelukast, we have the other additionals such as theophylline or azithromycin, although we recommend seeking advice and guidance from your secondary care provider when considering theophylline or macrolides in asthma. And you can escalate then to high-dose ICS LABA-LAMA combinations. And it's at this stage where you're getting to this point where really you should be thinking about referring into secondary care, because these patients may be eligible for advanced asthma therapies such as the biologics, which really can be transformative for our asthma population, and therefore require some additional phenotyping in secondary care. For patients where, and as I mentioned, that are not suited to this approach, the maintenance reliever therapy or anti-inflammatory reliever route, we do have a more conventional option where patients can go into regular low-dose ICS at the initial step with a SABA reliever, and then escalating to fixed-dose ICS LABA combinations with SABA reliever and the closed triple options with SABA reliever. So that is still an option, but again, we just need to be very cautious that this route is only used in those you have confidence that they will be adherent to their therapy. Otherwise, you have somebody who is receiving SABA-only therapy, and we know that that is a dangerous approach in asthma. So that's what page 2, after that disclaimer page, looks like in our guideline. We then have a much busier page, but it is very much the detail behind that first page with the pictures, just giving you how to actually prescribe those approaches with the doses. And then on the third page, we have some additional useful bits of information which you can use to support you. So ICS formoterol, some of the evidence behind it and some of the points that we've talked about. It also has some instructions that you can use or provide for your patient during an acute asthma attack. It has some advice about when to step up and step down therapy. So on this side here, talking about excessive reliever use being an indication that you may want to review asthma therapy and consider escalation. And for anti-inflammatory reliever, it's 7 inhalations of that reliever a week should prompt you to consider escalating to a MART or a moderate dose MART regime. Or if you're following the non-preferred alternative pathway, it'll be 3 or more SABA inhalers. We've got a few bits of resources still to add in terms of QR codes, but they will be coming. But otherwise, we have links to some resources which can help with guideline implementation. So without taking up any more of your time, final conclusion on the adult guideline. Really, this is a significant shift in terms of approach to managing asthma, favouring anti-inflammatory reliever across the asthma spectrum, which has significant opportunities to address the challenges that we've had historically with SABA overuse and consequently poor outcomes for our asthma patients. And by adopting these guidelines, we can not only benefit our asthma patients in terms of their outcomes, but we can also reduce the environmental impact of asthma and its treatment, as Artie has described.